or non-specific defense by lysozyme complements interferons and fibronectins. Similarly, the cellular defense mechanisms could be specific, mediated by the cell-mediated immunity, lymphocytes, macrophages, or non-specific, mediated by the NK cells and phagocytic cells. Now, dysfunctions in these normal defense mechanism will predispose an individual to develop these infections, and they could be because of the granulocytopenias, the cellular immune dysfunctions, humoral immune dysfunctions, or disruption in the local defense mechanism. If we talk pursue of the transplant recipients, the factors which contribute to infection include the pre-transplant factors such as the underlying medical or metabolic conditions like diabetes mellitus, malnutrition, prior colonizations, latent infections, lack of specific immunity, transplant factors such as type of transplant, like certain infections are more common in disease organ transplants, and infections in patients with ABO incompatible transplants are higher as compared to the ABO compatible transplants. Then surgical trauma, and then post transplant factors also play a very important role. That is immunosuppression chiefly, and they could be in the form of cytopenias or defect in the mucocutaneous barriers. So they will all predispose a transplant recipient to develop infections. Now, there is a certain timeline in which these infections are seen in solid organ transplant recipients. For example, in the first month, majority of infections are the post-operative nosocomial infections. From first month to 12th month after transplantation, which is a peak period of immunosuppression, the infections are the classical opportunistic infections. And the use of prophylaxis has results in the delayed onset of these opportunistic infections in patients who have received the prophylaxis, post-exposure prophylaxis. And after 1 year, the infections are chiefly the community-acquired infections. So this is just a tabular form to show you the timeline of various infections. So within first 4 weeks, we have chiefly the nosocomial infections because of the aspiration or line infections or root infections in the form of bacteremias and candidiasis, and very less often donor-derived or recipient-derived infections. From first month to 6 months or up to 1 year is the chief time at which we get the opportunistic infections, like bacterial infections, including mycobacteria, or viral infections, fungal infections, or the parasitic infections. After 1 year, it is chiefly the community-acquired infections and some opportunistic infections like pneumocystis jirovecii, late viral CMV colitis, HSV, or polyomavirus. So this table is just to show you the spectrum of various opportunistic infections which can be seen in our solid organ transplant recipients. The most common infections which are seen are the bacterial infections, followed by viral, fungal, and the least common infections which are seen in the transplant recipients are the parasitic infections. So among the bacterial infections, the E. coli, Staph aureus, Streptococcus are the common ones, and Mycobacterium tuberculosis. Among the viral, the CMV, herpes, and polyomavirus are the common infections. Among the fungal, the Candida, Aspergillus, and Zygomycetes are the most common opportunistic fungal infections. And parasitic infections are the least common, so their exact incidence is not known. So as I told you before, the E. coli UTI is one of the most common bacterial opportunistic infections. Then others can be Staph aureus and Staph epidermidis. Tuberculosis in solid organ transplants is 20 to 70 times more common than the general population. And it is seen because of reactivation of the latent infection in the recipients, or it could be seen because of transmission from the donors, or it could be a de novo acquisition of infections. Atypical presentations are common, although lung and pleura are the commonest sites, but the atypical presentations, extrapulmonary disseminated disease is common in the solid organ transplant recipients, and they can have a fulminant course. So this is a case of a 55-year-old male, 6 months post-renal transplant, presenting as a mediastinal mass. So biopsy was obtained, and the biopsy showed chiefly large areas of necrosis with phagocytic cells and nuclear debris. And on performing the ZN stain, we could see that full field of acid-fast bacilli. So this was a case of a tubercular mediastinal abscess presenting as a mediastinal mass in a patient who had received renal transplant. The second case is of a 48-year-old male, 7th month post-renal transplant, cervical lymph node biopsy showing again necrotizing granulomas with Langen giant cells, and again Zn stain showed numerous acid-fast bacilli. So the third case is of a 40-year-old male patient presenting with a frontoparietal ring enhancing lesion, and stereotactic biopsy was obtained, and this showed abscess. And when we did an acid-fast stain, we could see these gram-positive filamentous bacilli of nocardia. So nocardiosis usually causes the lung infections, but in cases of solid organ transplantations, the CNS is also a common site, and they're frequently present with the brain abscess. Now, among the fungal infections, the spectrum includes Aspergillus, zygomycosis, pneumocystis cerevisiae, histoplasmosis, cryptococcosis, candidiasis, coccidioids, and few hyphomycosis. The most common ones are Aspergillus, zygomycetes, and the Candida. So this is a case of a 20-year-old male post-renal transplant patient presenting with fever and non-productive cough for 2 weeks. CT chest showed a cavitatory hypodense lesion. So this is a CT of the same showing a cavitatory lesion with dense fibrous walls. So lobectomy was performed for this case, and the lobectomy specimen shows a 5x5 cavitatory lesion in the lung with black and necrotic walls. And microscopy showed necrotic pleura and adjacent lung parenchyma, and the past stain shows numerous ribbon-shaped non-septate fungal hyphae, which represents the hyphae of the mucor. And this is to show you the NVU invasion and the vesicle destruction by these hyphae. Again, a vessel showing destruction of the vessel wall, transmural necrosis, and filled with ribbons of mucormycosis. So the common site of infection for mucormycosis is the lung and the rhinocerebral area, but in cases of transplant recipients, we can see them in other organs, example intestine, kidney, even as skin infections, mucosal ulcerations, and subcutaneous swellings. So this is one of the publications from our fellow showing a reverse halo sign in mucormycosis. This is defined as a central area of down gross opacity surrounded by a dense area of consolidation, visualized on a CT image. Another case of a 37-year-old female presenting with fever, weight loss, and nasal obstruction post-transplant. An ENT examination showed black necrotic crusting of the hard palate and nasal turbinate. The Montu tests were negative, urine was sterile, and the blood culture was sterile, and the sputum for gram staining and AFB was negative. So the nasal biopsy showed large areas of ischemic necrosis, and in this case, apart from seeing the ribbon-like hyphae of mucor, you could also see slender parallel-walled septate hyphae with acute angle branching representing mucor. And this is the silver stain to show you both the ribbon-shaped hyphae of mucor and the slender hyphae of the Aspergillus with acute angle branching. So this was a combined case of mucor and Aspergillus infecting the nasal cavity. Another case of a 46-year-old male patient presenting with orbit and nasal biopsy. So the orbital biopsy showed again these plenty of ischemic necrosis along with ribbon hyphae of mucor, and this is to show you the NG invasion by the fungus. And the nasal biopsy showed presence of large areas of necrosis and hemorrhage, and we could see numerous ribbon-shaped hyphae of mucor. But it was interesting to see that in the other fields, we could see these fruiting bodies of the Aspergillus along with the typical slender hyphae with acute angle branching. So this was a combined case of mucormycosis with aspergillosis affecting the rhino and nasal cavity and the orbital mucormycosis. So this is to show you a case of intestinal mucormycosis in the setting of renal transplant recipients. This is the serositis with marked necrotizing inflammation and presence of numerous ribbon-shaped hyphae of mucor. On this case is of a 58-year-old male patient with graft nephrectomy, again showing ischemic necrosis with a lot of suppurative inflammation, ghost icon of glomerular and tubules, vessel wall necrosis, and on the special stain we could identify the hyphae of mucor within the parenchyma and also invading the vessel wall. So now move on to a case of a 48-year-old male who had a combined liver and the renal transplantation, presenting with headache and recurrent vomiting. MRI showed multiple conglomerated abscesses within the right cerebral hemisphere with mass effect. So this is a stereotactic biopsy, the same. So we can see presence of suppurative granulomas with multinucleated giant cells. And in this high power view, we can see the giant cells which are filled with these pigmented fungal hyphae, which are also present extracellularly. And this is to show you the fungal stain showing both the fungal hyphae within the giant cells and extracellularly. And since these fungi were pigmented with the Mason's Fontana stain, melanin stain, and they would demonstrate melanin in the wall of these fungal hyphae, and so they represent the pheohyphomycosis or dematiaceous fungi. They frequently infect the skin and subcutaneous tissue, but in the solid organ transplants, they can very well infect the brain and present as brain abscesses. So this is one of the publications of isolated cerebellar pheohyphomycosis in a patient with combined hepatic and renal transplantation. Now this is from our book. This is to show you the candidiasis of the kidney. So another important point I would like to highlight is that in the cases of bacterial, fungal, and viral opportunity infections, we frequently see granulomas. So there can be different types of granulomas actually what we see in the opportunist infections. For example, necrotizing granulomas are common in setting of tuberculosis, zygomycetes, aspergillus. Non-necrotizing granulomas can be seen in patients with candida and CMV, and suppurative granulomas are common in patients with actinomycosis and pheohyphomycosis. So they can give a certain clue to what we are going to see in the special states. Now, this is a case of a 35-year-old female patient presenting with papules in the skin over the neck, and on the dermis we could see collection of the histiocytes, and on high power view you can see presence of numerous 2 to 4 micron budding yeast forms within these histiocytes, and this is the past stain to show you the stain. And on the chromic silver methylene stain we can see this presence of narrow base budding yeast forms present both within the histiocytes and extracellularly, representing the budding yeast forms of histoplasmosis. So again, for the histoplasmosis, the common site of infection is the lung, but in case of disseminated disease, we can see infections affecting the bone marrow. We can see infection of the adrenal gland, the skin, the subcutaneous tissue, the oral cavity, larynx. All these, we can even see infection of the liver, colon. So in the case of post-transplant setting, we can see histoplasmosis in virtually every organ. So this is another case of a 6-year-old male presenting with hoarseness of voice. And again, this is the laryngeal biopsy. And again, we can see the presence of numerous narrow-based budding yeast forms of histoplasma. So this was a case of laryngeal histoplasmosis. And this is a publication on this case. So unusual case of hoarseness of voice due to laryngeal histoplasmosis in a renal transplant recipient. Now this is just to show you a case of histoplasmosis of a colon. This is from the images from our book Pathology of Opportunistic Infection. Now we move on to a case of a 35-year-old female presenting with papulonodular lesions over the foot. So initially the lesions were in the form of papule, and later they progressed to nodule and eventually become ulcerated. So this is the biopsy from that ulcerated lesion, showing ulcerated skin tissue, presence of necrotizing suppurative inflammation, few giant cells, and within this necrotic debris, we could see also presence of few epithelioid cells, and then we could identify on the special stain presence of these capsulated cysts with narrow budding, and they represent the cyst of the cryptococci, which are 5 to 8 micron budding yeast forms. So this is another case of a 38-year-old male with bilateral lesion in the lung, nodal lesions in the lung, and On biopsy, we could see large areas of necrosis and the alveolar spaces filled with this thick walled, narrow base budding yeast forms. So this was a case of pulmonary cryptococcosis. So again, the cryptococcus frequently infects the lungs, but in cases of transplant patients, they can cause infections of the present as a infection of the brain. They can even present as a skin infection, as in our case. And the thick capsule of the cryptococcosis can be demonstrated by mucicarmin stain, and also the capsule of the cryptococcus is rich in melanin, so we can even use a melanin stain to demonstrate the capsule of cryptococcosis. Now this is to show you the CSF sample showing negative staining of cryptococcosis on Indian preparation. And this is one of our publication, a rare case of combined pulmonary cryptococcosis and cryptococcal meningitis in a renal allograft recipient. So this is a case of a 40-year-old male presenting with bilateral hazy lung fields and in a post-transplant setting. And the lung biopsy showed presence of acellular fluffy exudates filling the alveolar spaces. And we could not identify any organism in HE. And when we did the fungal stain, we could see numerous cup shape and the crescent shaped cysts of the pneumocystis jirovecii. So neurocystis jirovecii frequently affects the lung in the post-transplant settings, and the infection, because of prophylaxis, is usually now seen after 1 year of transplantation. So as I told, before the use of prophylaxis, it used to occur in first 6 months and affected around as high as 10% of patients, but because of routine use of prophylaxis, pneumocystis pneumonia occurs late and it occurs months to years after prophylaxis. To move on to the viral infections, so this is from a 64-year-old male post-transplant colonic biopsy showing presence of loss of vascular pattern with ulceration on the endoscopy. Biopsy showing presence of basophilic inclusion in the stromal cells, which could be demonstrated by IHC. So this is a case of a CMV colitis. And another case showing presenting as an ulcerated skin growth, and within the site of ulceration, we could identify the presence of this endothelial cell showing nucleocytomegaly with basophilic inclusion and characteristic owl eye appearance. Also within the necrotic areas, we could identify the presence of these septate fungal hyphae with acute angle branching. So this was a case of combined CMV infection and aspergillus, presenting as a skin ulceration in a renal transplant patient. So this is a publication of the same case. And this is from our textbook showing you the characteristic OI inclusions of the CMV from a nephrectomy specimen. Now, this is a case of a 45-year-old male presenting as a lumbar area cystic lesion. And in this, we can see presence of enlarged cells with characteristic intracytoplasmic eosinophilic Henderson-Patterson body, which are around 35 micron in size. And this represents a case of a molluscum called the pox virus. Another case of a 30-year-old male patient. This is the esophageal biopsy. And in this case, we could see esophageal ulceration, and the high power view, we could see this characteristic intranuclear cowbell type A of inclusions with a perinuclear halo and frequent multinucleation. And this represents a case of herpetic esophagitis. So this is just to show you the HPV-induced condylomatous lesion from the genital area in a renal transplant recipient. Now, last but not the least are the parasitic infections. So this is a case of a 35-year-old male with a colonic biopsy. And in this colonic biopsy within the crypts, we can see presence of these 2 to 3 micron blue beads. They're described as the blue beads, which are attached to the apical surface of the colonic epithelial cells. And we can another field showing you numerous blue beads, and they represent the forms of the cryptosporidium, which can be seen frequently in the post-transplant settings. So the GI tract, including the small intestine, the large intestine, can be colonized by the cryptosporidium in the post-transplant settings. And these patients frequently present as diarrhea and malabsorption syndromes. Now, this is the case of a 46-year-old male with duodenal biopsy showing presence of atrophic duodenal villi. And on the surface, we can see these organisms, which on a high power, we can see these pear shape or tenosecond shape with two nuclei representing the trophozoites of Giardia. So Giardia commonly affects the duodenum and the jejunum in the post-transplant settings. So this is one of our publications on the Giardia mimicking acute dominant in renal transplant patients. So this is our other publication on BK polyomavirus nephropathy. Another publication in a BK virus setting presenting as a bladder carcinoma, which I also presented earlier in one of our ISRTP meetings. So apart from the histopathology, we can do ancillary testing for various opportunistic infections like serological testing, PCR testing, latex agglutination test, bronchoalveolar lavage fluid, especially for patients with tuberculosis and pneumocystis cerevisiae. Then radiological investigations also help in making a diagnosis and leading the pathologist. So the role of histopathologists in diagnosis of opportunistic infection is definite and inevitable. So histopathologists play a very important role in diagnosing opportunistic infections. In our lab, within 24 hours of receiving a biopsy sample, we are able to offer a diagnosis with special stains. Even earlier than all serological tests and culture tests usually take a long time. So histopathologists have to play a really important role in this area. H&E stain together with other special stains, AFD, PAS, GIMSA, Musicarmin, Indian, and IHC. Now, IHCs are available against many of these opportunistic infections, so they can also be helpful in making a diagnosis. So histopathology will form a gold standard for diagnosis of a majority of the fungal, viral, and parasitic infections, and some bacterial infections like the Mycobacterium tuberculosis and the nocardia. Prompt and correct diagnosis can be life-saving for the patients receiving the renal transplants. So this is our textbook, which we published in the year 2017. And thank you very much.
Well, thank you very much, Dr. Pallav. That was excellent. I think you deserve all the credit for a wonderful compilation of some excellent cases. So from the point of view of a nephrologist, Pallav, I would certainly want to know, did you try to correlate, as is the logical thought, that opportunistic infections will be related to intensity of immunosuppression? Have you been discussing with your nephrology colleagues as to what particular aspect of immunosuppression leads on to these kind of rare this thing? So could you pinpoint that this was a particular value level of tacrolimus levels or rejection episode getting treated, which results in these kind of infections? So I'm wondering what can really be done to prevent the occurrence of these.
Sir, fortunately, I do not have this data as of now.
Okay, but I think that will be very important to look into.
Yes, because it's really important.
So another important aspect, do you always correlate with the lab data? I'm giving you at times when there's confusion in the sense whether it is mucormycosis or aspergillosis. Would you want to bring in the role of a test like galactomannan? For that matter, even in the histoplasmosis, would you want to know the value of galactomannan, trying to correlate whether your diagnosis indeed is correct?
So actually, the if you look at the morphology of the histoplasmosis, aspergillosis, and mucormycosis is quite distinct. So only in a very few number of cases of aspergillosis or mucormycosis, we will be in doubt looking at the morphology. So we'll definitely like to, correlate with the other investigations like the galactomannan test or for that matter, culture of the species.
And finally, before I open it to Professor Gupta and Dr. Srilata, how would you, I mean, that's for the interest of the residents who have joined us today, how would you differentiate BK virus nephropathy from acute rejection? Because, they can at times mimic. So how categorically can you say that this is BK virus nephropathy and not acute rejection? And what if the two coexist?
Sir, in the setting of BK virus nephropathy in the stage 2, so we frequently see interstitial inflammation and tubulitis. But what we are interested in looking at is the presence of characteristic ground glass inclusions, and that we can very well demonstrate by the immunohistochemistry against the SV40. So we can make a confident diagnosis. And in certain cases where we are not able to see them in the cortex, so again we have to look in the medulla. So frequently they manifest in the medulla. So medulla is a very important tissue to look at the inclusions of the BK virus nephropathy. So other than we can correlate with the serological levels.
Thank you so much. And over to you, Professor Gupta, for your expert comments, sir. Can you please unmute yourself, Professor Gupta, please, sir? Yeah.
Yes. So
yes. We can hear you, sir.
Can you hear me now?
Yes, we can hear you, sir.
Okay. So the important thing is that in a transplant patient, sometimes the patient can have so much severe morbidity and mortality even with a functional graft. One has to look for, in these cases, in the graft biopsies or even in the non-graft biopsies for these infections. If these infections are diagnosed, first of all, they should be suspected. And then they can diagnose quickly, then it will be life-saving procedure. Otherwise, your patient may succumb to these infections with a functional graft. This is number 0.5. Number second point is that there should be increasing awareness amongst the diagnostic renal pathologists to identify these infections. Somehow or the other, still we find that many times these infections are missed. Now, there has to be consciousness for that. There has to be a pattern of recognition of these infections on histology as well as cytology. And number 3 is that even if you find one pathogen over there, don't forget that there could be more than one pathogen. And that will change your treatment. And fourth thing is, as you said very rightly, that sometimes there is a very much overlap between the rejection and suppression of rejection and the overload of the opposite infection. Now, this is a very delicate balance. What to do in this? So, in this case, I think the clinicians have to take a call that the suppression of the infection is more important at this level than the treatment or a very high doses of antisuppressants for the rejection. So, I think there are some of the points which have to be kept in mind for the occurrence of opposite infections in renal transplant settings. Thank you.
Your comments, Dr. Sita Lakshmi ma'am, your expert comments regarding the transplant opportunistic infections.
Pallav has given a wide array of cases in both bacterial, fungal, and parasitic infections. The viral, sometimes it is very difficult when there is a regenerative change or like whether it is a viral cytopathy. We struggle sometimes when 1 or 2 nuclei is showing some enlargement and some ground glassing. So definitely the IHCs will come as a help to us in that cases. And especially in cases of adenovirus, that can actually incite something like a granulomatous reaction, and it will most likely because it will be tubulosensitive. So that will cause a differential of other infective organisms like tuberculosis and all. So that also IFC is very helpful, and it can also cause interstitial hemorrhages, which will just simulate an ABMR. So these are the, in some areas in morphology also, there are differential diagnoses. And sometimes we will try to see an area where viral cytopathy is not there, if it is a long core, and see whether there are tubulitis in the other areas also, or whether it is accompanied by other features like a glomerulitis or a vasculitis or a peritubular capillaritis. So that will help us to just tell that there is an additional component of a rejection also. That is how we go. Actually, we definitely know that it is very important for you to differentiate between a viral cytopathy and rejection, because the treatment goes in like 2 different opposite direction actually. So yeah.
Okay. Quite true. And the last one for the paucity of time, again to you, Pallav. And I think you will have assistance of my dear friend, Dr. Ashwini Gupta by your side, wanting to know you see the importance of CMV. So many times the PCR may be negative, the serology, we may not have any clue yet. There is a tissue diagnosis, and that's the tissue invasive CMV. Would you recommend any tips to the person who's taking the biopsy as to what kind of specimen do you need so that we don't miss a diagnosis of tissue invasive CMV? Can you unmute yourself, Pallav, please? Can you unmute, please, Pallav?
So we
Yeah.
we would need we will need a sample from the lesional area in the paraffin tissue, so that we can perform the routine stain, and we can also perform the immunohistochemistry on the same. And it is not necessary that we will always have raised serological levels. So sometimes in the state of compartmentalization, we can see the invasive infection, but the serological levels may not be high. So once we are seeing the invasive infection in the tissue, it is diagnostic, and you can offer the patient the treatment.
That's the point I wanted to make. So many times, you see, CMV is such a common entity, and so many times the PCR report may come as negative. But if there is a high index of suspicion, we must go in for a tissue diagnosis. And so many times, the pathologists help us clinch the diagnosis. Well, thank you so much. It's been a lovely listening to you. I wish we could hear more from Professor Gupta with all his experience, from Dr. Sita Lakshmi, from her experience as well. But I think for the positive time, we will now may extend on behalf of the organizing committee our sincere thanks to Pallav for a wonderful talk and a great session. Thank you so much.
Thank you. Thank you.